AI can do certain things. It cannot participate in the quest for wisdom.
Dr. Arthur Kleinman is a psychiatrist and medical anthropologist whose work has reshaped how we understand illness and caregiving. For over 4 decades at Harvard, he has led efforts to bridge medicine and human experience.
If you didn't know the illness experience, you couldn't take care of the disease, okay?
Authoring landmark books such as The Illness Narratives and The Soul of Care that explore what it means to suffer, heal, and care deeply.
Communication is critical to medicine, but most American medical schools do not train in learning how to communicate to patients.
Today's conversation promises a rare insight into the human side of medicine, how we care, how we suffer, and why those stories matter. Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine. Arthur, welcome back to Stanford. You trained here. Tell me a little bit about how Stanford shaped your career. You've obviously spent most of your time.
Oh, absolutely. I was an undergraduate here and went to medical school here. And it was a different medical school.
Yeah.
And I was quite connected to the Department of Medicine because Hal Holman, who then was the chair of medicine, was a real good friend. And but it was a different medical school that was dominated by basic scientists.
Yeah.
And clinicians all the great clinicians had been left in San Francisco when the medical school moved down here.
Right.
And so you had just young clinicians who sort of didn't have the power to influence the education. Hence, we were educated more toward science than we were toward care. And my subject is care today, so that's interesting. But I'll tell you that when I left Stanford and was an intern in internal medicine at the Yale New Haven Hospital, the first day that I was an intern, the other intern handed off to me 17 patients, half of whom had MIs and pulmonary emboli, and I hadn't seen a single MI or pulmonary embolus here at Stanford.
Right.
Okay, and so I wrote back to Dean Alway and told him, you trained me scientifically, but you did a lousy job of preparing me clinically.
For the rest of the
So I was hoping that that would increase that.
Yeah.
But now I can see that it's a different place. You've got the facilities, which we really didn't have at that stage, and you've got the patient mix, etc.
Well, just a moment ago, we were talking about my homeland, Scotland, and one of the things I remember from my early training was seeing essentially multiple MIs every single day. I came from Glasgow in the west of Scotland, where the heart attack rate is as high as anywhere in the world it was at the time. I moved from there to Oxford, where it was a little lower, and then moved from there to Stanford, where it was much lower again. So in some ways, we've had a parallel early path there.
I mean, I went to do my OBGYN in Edinburgh at the, I think it was called the infirmary or something.
Yeah, the Royal Infirmary.
But since the midwives would not let us near delivering, I left after a week and came back and did it here at Stanford.
My mom was a midwife, actually, so I sort of grew up in a family where she ruled the roost on all things to do with babies. So, well, that's amazing, and you've had this incredible career, obviously based as a professor at Harvard. Medical anthropology is a field you almost essentially created, and when we read about you online, various words are recurrent. Medical anthropology, of course, psychiatry, ethics, but also medical education. But maybe start with that first one, medical anthropology, because not everyone is familiar with what that really is.
Well, it's interesting that probably at Stanford here, the hospital, if you asked attendings or residents, they'd have trouble with medical anthropology. If you came to the Mass General or the Brigham, the hospitals were at Harvard, or even the BI system, you'd find that people would give you a definition of medical anthropology, because we've had generations of terrific medical anthropologists.
Right.
My former students include Paul Farmer, who probably was the icon of global health in the world.
Absolutely.
Jim Kim, who was the president of the World Bank. Ann Becker, who is the dean of clinical and academic affairs at Harvard Medical School now, and many, many others, including maybe a quarter of the anthropology department here at Stanford.
Yes.
And so medical anthropology is simply the kind of medical anthropology I've tried to do, is applying anthropological ideas and methods to clinical care. And so the first thing is to recognize that there's really a close connection between clinical work and ethnography, the method of anthropology, which is just about, in a crude sense, learning about the context of people. And you hope doesn't happen all the time, but you hope that doctors are learning about the context of their patients in order to give better care.
Yeah.
Okay?
Well, that's what struck me in reading about your work, in particularly just in preparation for meeting you today, was that we often focus on curing. We're so focused on curing. And actually, we run away from that word for many years, but maybe now
Right.
we can actually approach it for some conditions. But I think what you've written about so potently is that it's not really just about curing, it's about caring and understanding the person behind it.
Yeah. You know, it's not an original idea with me or with you.
Yeah.
This has been going on for over 150 years. If you think of William Osler, who left Hopkins to
Yeah.
become the Regius Professor
Yeah,
at Oxford.
at Oxford,
His
yeah.
whole argument was about the importance of care for cure.
Yeah.
His point was, if you didn't know the illness experience, you couldn't take care of the disease.
Yeah.
Okay? And that's more or less what I've tried to show you can illustrate through anthropology better than many other ways. And then what methods do you have available? And the key method, I believe, is intensive interviewing. Knowing how to interview.
Yeah.
Knowing how to be, and as a doctor, you're in a privileged place for interviewing because there's a critical issue, something is really at stake, people are focused,
Yeah.
you're focused. As long as you keep your attention on the person,
Yeah.
you can quickly get information that you could never get in any other setting. And yet, something happens that, as a medical educator for 55 years, I feel is an enormous failure. Now, I'll leave Stanford out of this because
Yeah.
I'm sure Stanford does better than everywhere else. But I can put Harvard on
kind.
this, and Yale,
Yeah.
and just about every other university in the United States and its medical school. We have 8 major studies
Yeah.
that show that graduating medical students are worse than incoming medical students at all the things related to the medical interview, the medical history,
Wow.
and those emotional and moral aspects that relate to being committed to doing care.
Yeah.
So for a medical educator, that has got to be a problem. And for a chair of Department of Medicine,
Yes.
I think you're in the perfect place
Yeah.
to do something about this. Because my own diagnosis of this
Yeah.
is that what happens that makes medical school wonderful for science and technology, toxic for care,
Yeah.
is that, and again, I'm excluding Stanford.
Sure,
from
that's
this,
kind of
okay?
you. Just
Yeah.
current company experience.
Right, and so is that we allow residents to teach medical students.
Yeah.
So you and I you were a registrar, I was a resident.
Right. Right.
You're a resident, you're a survivor.
Yeah.
I wouldn't, if I had my ideals, and
Yeah.
I tried to get these at Harvard Medical School, but no one has given me the space for them.
Yeah.
I wouldn't allow a resident within 200 yards of a medical student.
I see.
okay?
I see.
Simply because you were a resident, I was a resident.
Yeah.
Being a resident is survivor.
Yeah. That is true.
You're in your mid-20s. You want to get out in the world. You want to have a life.
Yeah.
You can't be stuck in the hospital all the
Yeah.
time.
Yeah.
Okay? So you shortcut things that you shouldn't shortcut.
Yeah.
Okay?
Yeah.
And instead of seeing the occasion to really teach the best practices, you
Yeah.
actually end up not so much teaching the worst practices, but showing the worst practices, demonstrating them.
Yeah.
And there's nothing like demonstrating for a medical student to realize, hey, there really is a hidden curriculum here,
Yeah.
you know?
Yeah.
And so, at Harvard, when we were more divided, the last 2 years clinical, the first 2 years preclinical, we used to call the last 2 years the cynical years.
Yeah.
okay?
I see. Yeah.
The first 2 years,
Yeah.
the pre-cynical
Right.
years. okay?
Pre-cynical.
Yeah, yeah.
But I think that certainly one of the things you're speaking to is the idea that residents are involved in something very practical, right?
Yeah,
And so they're learning
yeah.
shortcuts and they're learning how to
Yeah.
get through the day.
Yeah.
And that's probably not the time of your life when you're most focused on how you might educate the next generation.
No, and as a chair at a great medical school, your hands are a little bit tied, I think, to pick service chiefs who really are important because they're going to demonstrate the quality of care,
Yeah.
for whom care is a central issue because in their careers, like in my career and your career, we had to build strong academic careers.
Yeah.
Not all of us kept care as a central focus, okay?
Yeah.
And yet my feeling is if you're a service chief on a clinical service, you must be an outstanding caregiver. And
Yeah.
if you're not,
Yeah.
everything is going to change.
Yeah.
And that service is not going to value care. Students are going to understand that.
Yeah.
Residents will understand that.
No, I
So-
completely agree. And it makes complete sense. And I think that your statistic about the data demonstrating that through medical education we make people less good at listening, less good at eliciting narrative, is, that's a strong indictment of the way we currently work. You're kind enough to exclude us, but in reality we're no different from anywhere else. And as a community, I think we clearly need to think about that. You've written a lot about narrative in particular.
Yeah.
And obviously, among your very famous books, maybe the one that most medical students have been most exposed to is Illness Narratives.
Yeah.
And but talk about that. I'm someone who loves story, and I understand just the power of story. But it's everywhere around, and I think no one has written about it more eloquently or importantly than you have.
Yeah, thank you for saying that. Well, at least it was early. I mean, there's a lot of attention now to narratives, but that was back in the late 80s.
Yeah.
Well, I'll tell you a misadventure with the illness narratives.
Yeah.
Because the illness narratives at one stage in the late 90s was taught at about half of American medical schools.
Yeah.
So it was widely used. And I would go to the medical schools, and they would take me on rounds, because I'm a clinician. And I would go on rounds, and we'd see patients, and they'd say, oh, this is the great patient for you, Dr. Kleinman.
Yeah.
This is Mrs. Smith. Here is her electrolytes, her all the hematological workup. This is her x-rays, and this is her illness narrative in one paragraph, okay? Yeah. And it was fixed. You see, it was her illness narrative in one paragraph. It materialized as a substance, okay?
Yeah, right.
Okay? But my whole purpose was, I don't care what the narrative is, it's meant to be a conversation opener.
Yeah.
But the way it got used was a conversation stopper,
right,
okay?
Right.
We've got this, we show it, that's it, okay?
This is end of story.
Exactly.
Yeah,
so my interest was really not in narratives.
Yeah.
It was in the illness experience. I think focusing on the illness experience, understanding it, that is, what is the person actually experiencing from this disease?
Yeah.
So, I made this distinction. It came out of the work of a great Yale clinical epidemiologist, Alvin Feinstein, who made a distinction between illness as the experience of the patient, disease as the pathology understood by the doctor.
Right, right.
And my concern was that the doctor had to understand both.
Yeah.
You couldn't just say, okay, I'm listening to the patient, she's telling me the diagnosis. Okay?
Right.
Yeah, you may pick up the diagnosis, but she's telling you about her life, okay?
Yeah.
And about her experience of being sick and of being treated.
Yeah.
And if you take that into account, you're going to do a hell of a lot better job for her.
Yeah.
And the people who do that job, patients really value. And the people who don't, they don't value.
Yeah.
I gave you an example last night in a lecture I gave of studies. We have a number of them now. These are medical anthropological studies comparing orthopedists and chiropractors for low back pain.
Yeah.
Okay? There's no question in these studies that the orthopedists have the better outcome. Okay? But if you look at patient satisfaction,
they are different.
It's astonishing. There's a paradox.
Yeah.
The patient satisfaction is with the chiropractors.
Yeah.
And when you ask them, when they're asked, why, how could you possibly find the chiropractor better than the orthopedist? They say, well, it was a real person.
Yeah.
They explain things to me.
They love their chiropractors.
Yeah. So, and what is that about? It's about listening. Someone listened to me.
Yeah.
They heard what I was concerned about, and they gave me an explanation that was important. And that's one of the most interesting things about medicine. Communication, as I'm going to argue in Ground Rounds, is critical to medicine.
Yeah.
And yet, we don't train, and again, I'll exclude Stanford, you may do it, but most American medical schools do not train medicals in learning how to communicate to patients, meaning just simply metaphors. So if you're doing hematology, what metaphors do you use when you have leukemia?
Yeah.
You want to speak to a patient about leukemia. Or if you're dealing with low back pain, or you're dealing with asthma, what are the metaphors that people will understand? Years ago, I was at the University of Washington for 6 years, from 76 to 82. I had a friend who was a great medical geneticist. His name was Arno Motulsky. And Arno asked me to evaluate his genetic counselors. And so I sat in on 10 sessions by genetic counselors with families, husbands and wives, who had just either delivered a child that couldn't survive much after delivery, or had been dead at the time of delivery. And they were learning about the genetics relevant to the unusual genetic problems that their dead child had had, because they wanted to plan for children in the future. And I had a medical degree, and I sat through these sessions, and I couldn't understand half of what was being explained.
Yeah.
So I just knew. I interviewed the families to find out what they knew. They knew nothing. Okay?
Yeah.
And when I spoke to the counselors, well, they must have understood it because no one asked any questions.
Yeah.
And you said, well, yeah, they didn't ask any questions because they were intimidated by you. Okay.
Yeah.
So I think that it's in reacting that we see doctors' skills in being caregivers.
Yeah.
You explain to a patient what's happened, and then they think about it. You say, come on, well, you must have a question.
Yeah.
They ask the question, and then you respond. And in that response, you really do the job.
Yeah.
You make it clear what's at stake, what's going to happen, how you're going to proceed, et cetera, what the issues are, what could be an unintended consequence. All that comes out.
Comes out if it's a conversation you're having.
If it's a conversation,
yeah. I sometimes actually ask my patients if they would explain back to me what they heard.
Oh, terrific.
And in one sense, I'm putting them on the spot, so you have to be careful. You have to be a little careful with that. On the other hand, it's really illuminating when you realize what it is they took from what you said.
Yeah. 2 years ago, a colleague of mine at Harvard, who was a great humanist, asked me to develop myeloblastic leukemia, and asked me to find the best person to do his treatment.
Yeah.
And I asked around. I got different names. I picked the Harvard colleague who had the best outcomes, and I arranged for them to meet.
Yeah.
And 2 hours after the meeting, this humanist, who was a great guy, called me and said, you have to get me a new leukemia expert. And I said, no, I got you the
best.
The best. And he said, I can't see him again. And I said, you can't see him again? Why? And he said, he was so cold and uninterested in me as a person. He simply laid out the odds ratios. And I felt that he could have been giving a lecture to 100 people rather than speaking with me. I'm not going back to see him.
Yeah.
So it's and then you say to yourself, gee, see, someone who is outstanding in treating the disease, why can't they also be skilled, at least skilled?
Yeah, in understanding the person.
A great author years ago, writing about his medical care, said, I didn't want someone who was extraordinary. I simply wanted the decency of the postman.
Yeah.
Okay.
Yeah.
And I thought that was a telling.
That's a really interesting phrase.
Yeah.
And I think that sometimes we just are losing that with our focus on the disease, our focus on the numbers, the odds ratios. We can lose that the personal connection that would otherwise naturally come first.
Yeah.
And somehow it gets lost. And even the way we teach how to take a history divides these components.
Yeah.
As much as a social history as taught is still pretty minimal. It's not really understanding the person. It's still separated from the disease history. And I think that, again, your writings have really spoken nicely to the fact those two can't be separated.
I'm hopeful for a couple of reasons. One, every medical school I know right now is undergoing curriculum reform in response to these 8 studies, amongst many other things, and trying to improve things. So that makes me optimistic. Secondly, I was just with a group, and I've been with a number of groups like this. I was with a group of surgeons and anesthesiologists in Montreal, all of whom were concerned about the loss of the human in care.
Yeah.
And they contribute this in part to the structure of surgery today.
Yeah.
So much surgery is day surgery that by the time the surgeon has entered the room, the patient is knocked out. Okay?
Yeah.
And by the time the patient recovers enough to speak, it's the resident who speaks to her, not the surgeon.
Yeah.
And so they wanted to know, how would you reconfigure things given the limits of our practice to make things more human?
Yeah.
Which I say, schedule an appointment in advance, where you speak to the person what's going to happen, lay it out, and then see them afterward as well. That could be and people said, well, we can actually fit that into the kind of system. So part of it is the system, because I believe that even though the finding is that fourth-year students just sort of lose some of the interest and some of the skills, it isn't that we've de-skilled them forever or changed their interest. They're going to come back to this after their residency, okay, later on in their practice. And what happens is, especially in primary care, is that we see alienation. This is classical Marxist alienation. All right. If you go back and read Capital, okay, I'm not a Marxist, but I read Capital. Okay,
Sure.
you'll see that the way Marx defines alienation is exactly burnout in primary care physicians. Okay, that you get alienated from the product of your work because the quality you would like to produce, you cannot produce. Your hands are tied, as it were, by the system. Okay.
Yeah.
And I think I'm older than you, so I can tell you that my generation screwed this up. And how did we do this?
Yeah.
We were so focused on our own interests in academic medicine and leading healthcare systems that we allowed economists and health policy people to entirely change the language in which we discuss these issues.
Yeah. Yeah.
So the term patient began to disappear. All of a sudden we had clients and consumers. Okay?
Right.
We had products. We'd never talked before
Yeah.
of care as a product,
Right,
okay? But care became a product.
Yeah.
And as I'll mention in Grand Rounds, the worst thing that happened is with an economic sleight of hand, we allowed health policy people to claim that they were measuring quality of care when what they were measuring was institutional efficiency. Okay?
Yeah.
Institutional efficiency is important. Hospitals got to survive,
Yeah.
but it's not quality of
No.
care. And indeed, at times, efficiency can run against quality
Quality of care, absolutely. How would you define quality of?
Oh, I'm going to do that in Grand Rounds.
Perfect. Perfect.
But I have a but I'll tell you right now that
Yeah.
I would define it in terms of the time and quality of the doctor-patient relationship. Okay?
Yeah.
The measuring communication.
Yeah.
And for the first time, I'm 84, so I won't be here to see the results. But you will.
Yeah, I hope so.
For the first time, AI is going to help us measure all these things.
I was going to get to that.
AI is going to help us measure the communication,
Yeah.
how responses occur, because so much of that communication is responses.
Yeah.
It's going to even help us measure the affective tone,
Yeah.
the emotional tone of a relationship. You know, as long as we use it
Yeah.
appropriately
Yeah.
and we pay attention to the results, we're going to have to change.
Yeah. Are you optimistic then about the effect of AI on medicine?
My belief is that chatbots cannot replace human beings as therapists because they're algorithms.
Yeah.
All right, they can do wonderful things in pattern recognition,
Yeah.
but they're not human beings responding to you, and there never will be. But they can augment tremendously what we do. So I'm sure that here at Stanford you use AI as medical scribes. It's fantastic as a medical scribe.
Yeah.
Okay? Better than most people recording things because
Yeah.
it can really focus and give you things. I think AI can measure all these elements of good care.
Yeah.
And for the first time, we'll have a measurement.
Yeah. What do you make of some of the data that suggests that even doctors judge some of the answers that an AI provides to patients as as showing more empathy?
Yeah. You know, I'll tell you why I don't believe that.
Yeah.
Because look into that research and look how AI is tested.
Yeah.
AI is tested against multiple choice questions, okay?
Yeah.
As soon as you put AI into the actual conversation that a patient has with doctor, first of all, it goes way down in its effectiveness, but it begins to have the same concerns that we have in actual natural communication. So I don't believe that it's better at these tests. What I think it does is it can be a backup, it can be help at the entry point. But let me tell you why I would not have AI take the medical history.
Yeah.
Okay? So we have very good research in primary care that shows that if you look at the history alone, medical history alone, taken by an excellent medical historian, 70% of all diagnoses later prove to be the right ones are made on the history alone.
History alone. Yeah.
Why give that to either a receptionist, AI? You want your best person
right.
doing that.
Yeah,
okay?
yeah,
It's the same thing with the physical exam. So that's the other thing that concerns me, even though I'm a psychiatrist. Okay? I always did a physical exam.
Yeah.
All right?
Yeah.
At the physical exam, of course, we have the technology that is much better at getting at mitral stenosis and ejection fractions than you could possibly do auscultating the heart.
Yeah.
But auscultating the heart is only in part getting at the disease, okay?
Yeah.
It's actually making that skin-to-skin connection where showing you, I'm accompanying you in this.
Yeah.
You're not alone.
Yeah.
I'm with you, and I have the expertise to really help you.
Yeah.
Okay?
Yeah.
I think that it's so sad to see residents across the country who basically have given up on the physical exam.
Yeah.
I just think it's...
One of the things that is really important to us here and in our department at Stanford is that while we embrace innovation, and we're certainly at the forefront of AI and as close to it as anybody in Silicon Valley, that we keep humanity at the absolute center of everything that we do. And that human connection, we're interested in technology where it can bring humans closer together. And that's one of the reasons why I think you and I are both optimistic about the scribes, because they actually fix a problem that I think technology created. It put a computer in between us, in between the two humans who are most key. I think the AI scribe can now take that computer away and just listen in the background, offer some help with obviously documentation that comes later, but allow then the two humans to make that connection.
I agree with that.
Yeah. And I think as a traditionally trained in an old medical school, two old medical schools, Glasgow and Oxford, physical examination was very important to me, and for all the reasons you say, that connection with the family, with the individual is vital.
Actually, the UK was very important in setting me in my journey. When I was a Stanford medical student, I spent 6 months at the National Hospital for Neurological Diseases at Queen Square in London.
Yeah.
And something happened during that time that stayed with me my whole life. And I wrote about this in The Lancet. I was a very good student, and I was the only student given the same responsibility as the registrars. And I worked up a case fully neurologically and presented. And this is the case I presented. 23-year-old consular officer in the British Foreign Service on Malta, a virgin, just married, in his first act of coitus with his wife, also a virgin, blew out an AV malformation and created a dense hemiparesis.
Wow.
Okay? I presented this case to one of the great neurologists of that time, Sir Dennis Williams. Okay? And Sir Dennis went over in detail the neurological exam that I did. He said, Kleinman, yes, got it right. Next case. And I stopped. And I did something which, you'll appreciate this from the British tradition of grand rounds, made all the registrars move away from me, okay, as if I were radioactive. I said, Dennis, don't you think we have more to do than just this? Because this is a tragedy. This is, just think about this, is an incredible tragedy. Okay? I'm speaking to them. They can hardly speak without breaking down in tears. Can't we do something? And Sir Dennis then did something which both did two things and instructed me again. That he had two sides to himself. He was a great technical neurologist at Queen Square, a public hospital. But he had a Harley Street side from his private practice, because he brought them back in and gave them the most sensitive interview and suggested all kinds of things, that from having a social worker and to all kinds of aftercare rehabilitation things. But he never would have said any of those things if I hadn't had provoked him. And I really did provoke him, because he began his response very superciliously, like, who are you?
Yes, it's very hierarchical.
Like the book of Job, where God sort of blows away Job and says, who are you? This is what, but he could do that. And that was the second part. It made me realize, why didn't he do that? And that was the social determinants. That's the social determinants of healthcare. If you paid him, he did it. If you didn't pay him, he didn't do it.
You spent a lot of time in China.
Yeah.
Tell me the unofficial story of why you went to China.
Oh, the unofficial story is an interesting one. I've never really written it down fully, but I should. It's because when I was a medical student here at Stanford, I ran into a beautiful woman who was being courted by 3 other people. And one of them would become the governor of the state, California, Jerry Brown. And the 2 others came from extremely wealthy, well-to-do families. One was the scion of the Bird family of Virginia, and they had horse farms. And the other one was, you would know this, was a family of Scottish jam makers. They made jam, and they had a castle
Robertsons, maybe.
Yeah, Robertsons, yeah.
Right.
Robbie Robertsons. They had a castle in Scotland.
Wow,
And so
okay. That's stiff competition.
That was stiff competition. So I got a leg up by learning Chinese because my wife was a China scholar.
Wow.
Okay.
Okay.
Yeah. So that's how
remarkable.
I learned
So you
Chinese.
started learning Chinese, and then
Yeah.
eventually
Yeah.
you
Yeah.
went to China.
That's right. Yeah.
That is amazing. I knew there was an unofficial. I didn't actually know the detail. Amazing. I mean, that's been such an important part of your writings and your thinking over the years. Where is that today? I mean, there's no more complicated geopolitical relationship than between U.S. and China right now. But you're someone, again, who really, I think, can speak to the cultural differences and similarities.
Minutes before we started talking, I was on my cell phone. And as you know, the government is giving Harvard a hard time right now. And one of the ways it's doing it is that we have this screening that we must have for all international attendees at any kind of Zoom meeting or any sort of open meeting we have, a real person-to-person meeting.
Yeah.
And I was just going back and forth about screenings for a big research project I have in China on social technology for elder care. And we have to screen all kinds of people because we've been so productive. The National Museum of Science in China is going to do has a space for us for a 2-year display of our work.
Wow, okay.
But now we have to have everyone there screened for things. And so why are we doing this? Well, when I started with China, we were kind of in the same position. I started in Taiwan because we had no relationship with China.
Right.
Relationship was with Taiwan.
Yeah.
When China opened up, I went to China with my wife, and I worked there ever till now. There was no reason, actually, politically for us, in my view, to make China an enemy. A strategic competitor, yes, okay?
Yeah.
But we don't have to be adversaries.
Right.
And even if we are adversaries, I had a model from my colleagues who were my teachers during the Cold War, who kept a relationship between individual Russian and American scientists, and you had this in the UK, going in spite of what the government relationships are.
Yeah.
And I think that's how I see myself now, that I have so many former students who are outstanding psychiatrists and anthropologists in China. They're in the tops of their profession. They've got great research going. I want to support them, and I also believe that in going back and forth, we help each other.
Yeah.
Okay, and so I'm deeply connected into the exchange between the U.S. and China, and I think that this is going to become the most important for the world going forward.
Yeah.
Since these are the two great economic powers, these are two great centers of science and technology, et cetera. And just keeping the friendship relationships going, trying to collaborate on things that are not so sensitive politically. That's what I'm trying to do. I've learned an incredible amount from working in China. I'll just give you one example.
Yeah.
When I first went to China, I brought the Western concept of resilience, and my Chinese friends, in the most polite way, disabused me of it and said, you know, this is a kind of an American Hollywood idea.
I see.
You know,
Yeah.
as you as a culture become more mature,
Yeah.
they didn't say that directly, but that's what they meant.
Yeah.
You'll understand that, you know, life doesn't always end up well.
Yeah.
And what life is basically about is enduring, learning how to endure.
Yeah.
And endurance has joy in it,
Right.
and it has happiness,
Yeah.
but it also has, you know, problems and
Yeah.
irritations and failures. And that's exactly right. And so I believe, after taking care of my late wife for 10 years, that our lives are about enduring, learning how to endure,
Yeah.
learning how to endure with joy, with momentum, with productivity, etc. But not having the idea that we're resilient and we're like a rubber band that you can stretch as broadly as you want to, let go, and it comes back to its shape.
Yeah.
When you're doing family care, or even when you're doing professional care with patients with neurodegenerative disease, almost all of whom are going downhill, okay? it's like the rubber band was put in the sun for 3 days and baked.
Yeah.
It's brittle. When you stretch
Yeah.
it, it breaks.
Yeah.
And we're all broken in a way.
Yeah.
I think even clinicians
Yeah.
have a little break in them. And I think that's crucially important.
Yeah.
That makes us willing to be vulnerable, okay?
Yeah.
And to say, we really are not sure, we don't really know. I think at my age, what I've become liberated to say is, I don't know, I really can't tell you what is going to happen now. There's certain possibilities here.
Yeah.
Let's see how they
Yeah.
develop, right? You get to a stage in your career, in your life, where you're able to be honest about your vulnerability.
Yeah.
Earlier in your life, you're not. And I think whole professions
Yeah.
are this way. So not your field, internal medicine,
Yeah.
but I think there's another field, which is neurology, which because of vulnerability is not a great field for caregiving.
Yeah. Mm.
And if you think of that field, it's a fantastic field for diagnosis, okay?
Yeah. Right.
It's an intellectually exciting field,
Yep.
okay? But because you have post-stroke patients, ALS, Alzheimer's, et cetera, and these patients are elderly and they're going down,
Yeah.
okay?
Yeah.
I think it would be difficult for a neurologist to allow that vulnerability to be too open.
Yeah.
And hence, they don't get involved in aftercare at all.
Yeah.
So
That's really
I'm going to
interesting.
make this point
Yeah.
in grand rounds.
Yeah.
I had a friend, a really good friend, who was one of the great neurologists
Yeah.
in Boston, okay? One of the world's great neurologists. He made the diagnosis of early onset Alzheimer's disease in her complicated case probably 18 months earlier than it would have been made, even if we had used a PET scan at that time.
Yeah. This is in your wife.
This is my wife, yes. And that was his gift to me,
Yeah,
okay?
yeah.
He spent 2.5 hours with her
Yeah.
in the most complicated set of examinations.
Yeah.
And at the end said, this is early onset Alzheimer's disease.
Yeah.
That was his gift to me. He had nothing, this was a friend.
Yeah.
He had nothing to say to me
Yeah.
about what to do.
What to do
Okay.
next? Yeah.
He's dead now, and I think he should be here to defend himself.
Yeah.
But I think that was not the way he thought of his field and his responsibility.
Yeah.
It ended with the
The
diagnosis.
diagnosis.
Okay?
Yeah.
And because there were no treatment.
Yeah.
Okay?
Yeah.
So my suggestion is that we got to figure out how, because neurologists are so critical in neurodegenerative diseases, how can they, in fact, do those things that are critical for patients around care? And what comes next? Yeah.
And you've written so beautifully and touchingly in your book about caring for your wife and this balance between love and care, empathy, and resilience, and the dedication that is required. That is sort of the defining text, I think, in the sense of someone with your background who found himself like in the middle of that very situation.
Thank you for saying that.
Yeah, really just amazing words. And we're going to have to, I think we're going to have to wrap up, unfortunately, to get you to grand rounds. One of the phrases that came to mind when I was reading through some of the work that you used, I can't remember which one it was, but you said the wound of knowledge is what anthropology shares with literature. And I thought that was a really interesting place maybe for us to end, and maybe have you tell us what you meant by that. And
Well, I meant something very straightforward. With 3 other colleagues, I teach a course at Harvard called Quest for Wisdom, Religious, Moral, Aesthetic. And we have a book coming out from Harvard University Press, will be out next fall, with that title, Quest for Wisdom.
right.
And I feel that medicine and anthropology intersect with human experience in part around people's quest for wisdom.
Yeah.
And this is why I feel that AI can do certain things, but it cannot participate in the quest for wisdom.
Yeah.
Okay? It can participate in the quest for information,
Yep.
okay, but not for wisdom. And what is wisdom? Wisdom is what Aristotle called phronesis. Aristotle said there were 3 kinds of knowledge. There was techne, which is your technical knowledge of your field.
Yeah.
There was episteme, which is your epistemological knowledge of how we know. But the most important, he said, was phronesis, which was practical knowledge about how to live a life, how to live a life of purpose,
Yeah.
a good life. Okay, he thought that was the most important, and I think that is about wisdom,
Yeah.
and that's where medicine and anthropology also intersect, because we're intersecting with people, especially at end of life, who are trying to have a wisdom about how to die, about how to live the last part of life. And I think that really good clinicians know that intuitively and contribute toward it. And I think that really good patients actually can teach clinicians about this. So if you let me just end on this note.
Yeah.
Henry James wrote a wonderful short story that every doctor should read. It's called The Middle Years, and it's in a collection of his work called the Aspern Papers. And in this story, he has an elderly writer who's a world-famous writer who's dying and being taken care of by a young doctor.
Yeah.
And the elderly writer intuits that the young doctor has a secret. The secret is the young doctor also wants to be a great writer. And so at the end, the elderly patient tries to convey some wisdom, in Henry James's words, to the young doctor, both for medicine and for writing.
Yeah.
And this is what he says. He says, we work in the dark. We do what we can. We give what we have. Our passion is our doubt, and passion is our task. So what's so interesting about this, our passion is our doubt, because everything we've learned in medical school, everything you learn as an undergraduate before you become a writer, makes you critically minded.
Yeah.
You critique your passion. But at the end, Henry James doesn't say critique is or doubt is your task. Your task is passion at the end.
Yeah.
And I think that's what we want to somehow bring back, an evidence-based, technologically sophisticated medical passion.
Thank you so much. What a lovely note to end on. Thanks for being here at Stanford.
Sure.
Thanks for everything you've contributed to our field, and thanks for speaking at Medicine Grand Round.
Thank you. I appreciate it. Yeah.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.